So now let's move on to panel discussion. Today we have 5 distinguished panel, Man-Won Park, Dr. Man-Won Park, Sang-Hang Lee, Eun-Ho Choi, Yoon-Suk Choi, Eun-Chu, Yoon-Suk Choi, and Sun-Jun Hong. Now we will have an open discussion.
Can I start first? Hi, Paul. I'm Sun-Jun from ICOLA. We have met a few months ago in Austria, Graz, and looking forward to meeting you in September next year. And thank you for your educational talk. And you have mentioned in your talk that COLCA trial and LODOCO 2 trial, they have, by using low-dose colchicine, have reduced major adverse cardiovascular event. And on top of statin, right? And were there any adverse event associated with low-dose colchicine from those trials?
Sure. So it is very nice to see you. I did enjoy meeting you in Graz, and I very much look forward to coming to Seoul next September for the ICOLA meeting. And let me also begin by congratulating Professor Kim on his elegant talk and the highly creative work linking CAP1 with resistance. It's very interesting work that we hope will lead to some novel therapeutics. In your question about the low-dose colchicine trials, it's actually quite interesting how safe the drug was. There were some gastrointestinal difficulties, which is common when you initiate low-dose colchicine. In the COLCOT trial, there was a small increased risk of pneumonia, but it was very small. There was no increased risk of infection at all in the low-dose colchicine LODOCO 2 trial. There was no neutropenia. There was no increased risk of cancer. Low-dose colchicine has been used for quite a long time in tens of thousands of patients who have familial Mediterranean fever. That's not something we commonly see in the United States, but in the Middle East, many thousands of patients take colchicine on a regular basis for this. So I think the drug's actually very, very safe.
Yes, I have a question to Dr. Ritke as well. You showed us the figure comparing the relative risk among the several studies. When you focus on the COLCOT 2 and LODOCO 2 and COLCOT trial, COLCOT trial included the recent MI population, and LODOCO 2 included the stable CAD patient. However, the effect of the low-dose colchicine is better in LODOCO 2, including stable chronic CAD patient. Well, usually when we think about the higher risk patients, the better effect when we usually think it. But why the effect of colchicine is different even in the higher the population? Second question is that the low-dose colchicine effect in stable CAD patients is abundant, right? It's a form. However, in case of the acute coronary ischemia, the effect of colchicine is controversial. It's an issue of the lack of power, or there's another hidden mechanism that we don't know yet. Could you explain us? Yeah.
So they're both very important questions. So to me, the COLCOT trial is also a trial of chronic stable atherosclerosis. Yes, they're within 1 month of a recent myocardial infarction, but most of them are 15 days out, which, it's pretty much stable disease into the phase. I think the relative risk reduction observed in COLCOT, which you correctly point out is 23%, as compared to LODOCO's 2 of 31. The 95% confidence intervals overlap. So to me, they're relatively similar. But I agree with you. In the setting of acute coronary ischemia, we have no idea if these drugs work. There's some very small study, the COP study, other studies that have been neutral so far. There are some larger ongoing studies. But I think the biology is quite different. I think in acute ischemia, we've learned that it's thrombosis, it's fibrinolysis, it's reoxygenation of the tissue. Yes, there's a profound inflammatory response very early, but we don't yet have evidence about inhibiting that response chronically. Now, I did mention the Artemis trial with interleukin-6 inhibition. It will start the drug at the time of acute coronary ischemia, but we're going to treat for 12 months because just like you, I think it's a long-term inhibition of the inflammation that will drive the benefit for us. But we'll see.
I have a question, very practical questions. That we have a lot of chronic stable inflammatory patients such as the rheumatoid arthritis, chronic inflammatory intestinal disease. What do you think, who is the best candidate for the calcium low dose therapy, and what is the optimal duration of the calcium for the CV preventions?
So we are giving low-dose colchicine to patients who have residual inflammatory risk and have chronic atherosclerosis. So patients who are chronic stable atherosclerosis in whom we've measured both LDL and CRP, and the CRP remains elevated. This is the patient group that we're focusing on. I'm happy that you mentioned patients with rheumatoid arthritis, inflammatory bowel disease, Crohn's disease, psoriasis, Addison's. It turns out that all autoinflammatory disorders have accelerated atherosclerosis. So it seems that whatever this signal of inflammation is, the vascular endothelium is seeing it as an adverse issue. And so probably we need to treat these patients on a very long-term basis. So the colchicine trials have treatment up to 3 or 4 years. I'm going to guess it's very similar to a statin. You probably will be treating these patients for very long periods of time. And it'd be hard to imagine why you'd stop the anti-inflammatory therapy unless there's adverse effects.
Dr. Didka, I'm Kyuk. So I was impressed by your lecture. So my question is, when I see my cardiovascular patient in the outpatient clinic, I realized the focus a little bit changed from atherosclerosis to vascular calcification. So especially in the super-aged society. And I think the interleukin-6 inhibition or the colchicine might reduce chronic calcification or any other calcification of the vasculature. So do you have any idea in this area?
Well, there's a great deal of experimental work going on directly addressing your very important question. What we know is that we're getting fewer atherosclerotic events. That's what the data tell us. Remember, though, it took us a long time to learn that statin therapy, if anything, increases calcification. So I think with the anti-inflammatory drugs, we still don't have a very clear sense on this. I know you're aware a lot of very elegant imaging work with CCTA, particularly in Korea. There's a huge amount of CCTA work going on. And it's been very influential understanding what kinds of drugs can alter plaque, whether or not changing calcium can help us. I think from a pragmatic clinical situation, we have to start measuring inflammation just as often as we measure LDL cholesterol and we measure blood pressure. I've said this before that when we're in clinic, I can't imagine treating LDL cholesterol without knowing the LDL level. I can't imagine treating blood pressure without knowing the blood pressure. But many physicians are thinking they're treating inflammation without actually measuring the high sensitivity CRP. We have to get past that, and our guidelines have to get past that. We have to recognize how important this inflammatory process is as we move forward with therapy. Because again, I want to come back to Professor Kim. He was making a very good argument that combined lipid lowering with aggressive anti-inflammatory therapy is likely to be the future of atherosclerotic treatment. And I fully agree with that. I think that that's where we're heading, and how we get there, whether it's with a CAP1 resistant molecule or we get there through some other mechanism, that's what's fascinating to me.
Regarding the association of coronary calcification and inflammation, statin may reduce the inflammation, and actually it may alleviate calcification. We published a paper in PLOS Biology about 10 years ago regarding the mechanism of vascular calcification. The mechanism is shown like this. The bone marrow-derived mesenchymal stem cells are circulating. They home to inflame the plaque, and then they may change the fate into adipocyte or osteoblast. Thus, in the presence of cytokines, they may tend to differentiate toward osteoblast, leading to calcification of vessels. In this point, when we activate PIPA gamma agonist is a kind of regulator of transdifferentiation of mesenchymal stem cells toward adipocyte or osteoblast. It can block differentiation toward osteoblast, alleviating vascular calcification. Thus, in this context, I think the initial trigger of homing of osteoblastogenic mesenchymal cells to plaque is inflammation. Thus, when we captured inflammation early phase of plaque, we can future prevent coronary calcification.
I'd like to ask you, Dr. Kim. So you showed very strong association between CABAN and PCSK9 and inflammation. And you performed a lot of animal experiment in animals of having metabolic disorder. So they showed increased level of PCSK9. So my question is, in patients with metabolic syndrome, they may show increased level of PCSK9. So
in the review process and the revision process of Nature Communication, they request us to check the human sample. Thus, we prepare the human circulating monocytes from healthy control without statin treatment from patients with CAD undergoing coronary stenting or coronary angiography treated with statin. To our surprise, the level of PC9 in monocytes or circulating blood is lower in a healthy population and higher in the patients because of statin treatment. The statin induced not only transcription of LDL receptor, but also PC9. The statin treatment significantly increased PC9 level in circulating blood as well as monocytes. It's very interesting. Thus, we may need another anti-inflammatory agent to just compensate the side effect of statin therapy to increase PC9.
Okay, Dr. Kim, you said this is CABAN play important role in inflammation. So, however, as far as I know, inclisiran siRNA also failed to decrease hsCRP level, although PCSK9 level down by more than 80%. So, how can you explain?
I guess inclisiran may be better than avalokumab and allokumab. As I mentioned before, the scheme. Inclisiran significantly reduced amount of PC9. Thus, that may reduce cholesterol level as well as inflammation. Thus, in comparison with avalokumab, I think inclisiran may have a double action. Of course, there may be some weakness to suppress the anti-inflammatory molecule by inclisiran, but I guess that may be better than avalokumab or allokumab. We need more extensive data. And theoretically, when we effectively block PC9 and cap binding, we can erase the inflammatory signal. But I guess inclisiran may reduce PC9 amount, not totally, just 80% decrease. Then there is still remaining signal between the remaining 20% PC9 and cap that may trigger some maintenance of inflammatory signal. But actually, inclisiran may be a better strategy than a blocking antibody like avalokumab.
Thank you for all the questions and discussions. And then the session time is over and the next session is waiting. So I enjoyed the lectures and discussions. So especially thank you for joining this symposium, Dr. Lidker. And we are all looking forward to seeing you next September in Seoul. And I'm going to close this session. Thank you.
Thank you. I look forward to seeing you.